So this is a angiogram from April of a 53-year-old presented in another hospital with inferior MI. They did this angiogram, and as you can see, there is critical left main, distal, the right is occluded. So he's got a single patent vessel, and he was for some reason left on medical treatment after heart team discussion. His actual EF is around 30-35%, and as you can see from this picture, the arrow, this zooming in, that is around 80% left main. This is his pre-PCI echocardiogram, which we check it on the day of the procedure. As you can see, the basal segments do move, but the distal septum, mid to distal septum apex are hypokinetic, and overall EF is around 30-35%. And the diameters of LV are pretty okay. It's just the apical part that seems to be akinetic, but it's the wall thickness is fine, and so probably it's viable. The inferior wall is moving well despite the right coronary artery being obstructed. So this is his. You can see now that the apex is, and as you can see, especially the septal part is not moving. The inferior wall seems to be moving well, and despite the right. Clearer. So it might have been the right could be a CTO or that the apex is previously, and the anterior wall is as expected hypokinetic.
Okay, so this is a very highly complex, unstable patient who had a inferior MI 6 months back. He's 53-year-old, and for some reason he was left on medical treatment after consultation, various consultants, including a heart team discussion. His LV is nearly normal, it's around 40-45% with apical hypokinesia, and his right is occluded. And as you had seen in the previous angiogram, it is sitting on a critical left main distal. Now this man does hard work, and he started having class 1 angina, then class 2, and now he's getting resting angina, can hardly walk 10 yards without getting chest pain. So clearly he has totally refused bypass. So there's no other option left. So we prepared him. He's got a calcified vessels and a critical left main. So as you can see, the wire is in, the guider is in, the wire is left there, and we take him on without doing a balloon pump. We prepared him, but there's no mechanical support at the moment. So you can see that with the second wire in, I am giving him an injection to try and get into the circumflex, because this is just like a thin thread, and his circumflex, although not too big, but has got severe narrowing. So clearly that circumflex with an occluded right needs to be protected as well. So as you can see from this shot, there is a severe narrowing in the ostium of the, and this is going to occlude if I just go and fix the LAD. You can see that this circumflex has a critical narrowing also here, and therefore cannot be just left as it is without a wire. So we are trying to get a wire in, and so using a fielder, because the normal work through would not go through, so a 0.09-inch wire in. So you got the wire in. The next step is to change the initial wire from a diagonal or a high diagonal or a ramus back into the LED. Now remember that all through this time there is a balloon which is lying here in case the patient goes down. His blood pressure had gone down from 160 on to 90-60 and over 70-80 systolic on wiring. So we waited and gave him inotropic support rather than putting in a balloon pump. But under normal circumstances, one would put a balloon pump here. But I took a chance, and because LV was not too bad, didn't want to put a balloon pump initially and put a wire and just saw how things are going. So we ballooned the distal left main, and so this clearly is, you can see, still significant recoil, but still better, very tight lesion in the diagonal, in the circumflex. So now the next step is to do kissing. Don't want to have this plaque shift anywhere else, and to maintain integrity of the distal left main, we did a kissing balloon. I did a kissing balloon, and didn't make much difference to the recoil. There's still, so this time, because of severe recoil here, and so the decision now was that we needed a 2-stent strategy rather than a single stent. So the LED is wired, but there is some distal occlusion here, and you can see now that there is a dissection, but it's on the lower end, not on the roof, and therefore, and it's still stable, patient stable now on inotropic support, but this also shows that there is a lesion in the proximal LED as well, and this is all calcified. So now we are not still sure whether this is ramus or higher diagonal, but at the moment we have to concentrate on this area and stabilize this. So now this does show that whatever it is, high diagonal has got a lesion here also. So this then induces me to put a third wire in and use the balloon to balloon this area, and so now this is out of the way, and I can now think about crushing a stent in this left main. Okay, so in this next part is to dilate this, because this is calcified and the stent wasn't going in. It didn't show you the CD there. So after dilatation with a 2.5mm balloon, managed to get a stent in here. So this is a long stent, thin struck stent, and placed it a couple of millimeters inside with a balloon in the LED to crush it. And as we inflate it, the stent seemed to come down, and maybe there's a geographical miss there which we'll take care of later. So, and then the next step is crush, and it's not very clear, but in this we may or we may not have had a geographical miss in this area. But this is better, all the rest of the vessels are preserved. So now the next step is to recross, even though we may have missed it and this was a no crush, but in any case we crossed distally with the wire again, and now did a kiss with opened the strut out with a 1mm, and then did a kissing balloon, and then put a NC to finish off this issue with a 2.5 to optimize this, and then you can see that we are doing multiple balloon inflations as the first case in our decay crush strategy. So now the things are stable. This is much better, still calcified, not properly prepared, but not too bad. So now in detail, because this is a teaching case for myself and for my students, so now go on to another view, and you can see in this view that you have a lesion here which needs to be taken care of. The bottom of the left main got a stable dissection which is not going anywhere into the circ or causing any flow abnormality, so I can persist. Now the wire is not gone distally, so I have to think about the LED. So first what I do is pull that Holocaust wire back and use a Fielder XT to go distally and through that occlusion side, and try and fix this, reconstruct this LED. So as you can see, there is a dissection and quite a lot of disruption in this area, calcified, but I feel that needs a stent. So we put a stent here, 2.25, and so now it's looking better, but there is an edge dissection here, and it's not too good, the distal LED. So I want to now totally reconstruct it. In another view, I'm now going to put a stent in the proximal part here, and so we put a 2.5 stent here, and then looked at the other things in the other views, and this seems okay. The LED is now open, but distal needs still to work on the distal area. This is just to see, now it's confirmed that this is a high diagonal rather than LED, ramus. So now we're going to fix the left main. So a long stent into the left main, we have to place it carefully. So now placing the left stent in multiple views, overlapping it, you have to guess the size. So this is around 22 millimeter. As you can see, it's hitting the bottom but not the roof of the, is not covering the roof. So I think this is probably okay to leave a couple of millimeters of the healthy left main here. So this is a 3.5 thin strut strength. There is a persistent dissection. So we do that, and you can see that we are okay. We just missed this part and the stents there. Now we are safe, and the next step is to check that everything is working okay. So this seems okay. This is a overlap view, so we can't see the ostium of the circumflex, but this seems okay. The stent is all the way up here. So next step is to pot it with a 4.5, first 4 and then 4.5 millimeter balloon, and so you can see that we have potted it, and now we are working on the bottom here to optimize this post-stent area. So after we've done this NC here and the stent which was deployed earlier, you can see that there is a dissection here, and the stent is really open and everything seems okay for the moment here. So from this area onward, we are going to now, the wire, as you can see, had twisted. Now how am I going to get this distally? This wire had twisted. So I'm going to get it distally by putting a 1 millimeter balloon, then pulling the wire back and then trying to go distally so that I can fix this area here. So a lot of ballooning, and then I needed to get a stent in. The stent, another 2.25, didn't go in. So now this wire is also twisted. So that's a problem. So what I did was, we did a NC high pressure dilatations here, fixed this up so that the stent and everything else up here is okay, and seems okay now. And so the next step is to try and dilate this area with a 2 millimeter balloon, and then change the wire to a BHW, and then just push this stent in. And it's going to take some pushing and pulling, but you pull on the wire and you push on the stent and keep this area looped, and so this area looped, and you push here and this area, and hopefully the stent would go where it's supposed to land. So now you've got the stent in, and you do the necessary things, and you can see that now this area is fixed. There's some flow going. I don't want to put any stents here. So now the LED looks pretty okay. You can see that everything seems okay here till now, but now on this shot there's something is amiss. You have to keep looking, and you know that there's something fishy going on in this area. And this is clearly not very good, because this area here seems to be deprived of a stent, and this is clearly a longitudinal dissection, a longitudinal distortion. So we put another wire, we use recross the wire, and now we have to fix this. This is very clear that there is a longitudinal stent distortion. The thin front stent has come off, and this area here is bare. So now we, after the distortion, we fix this everything, try and get rid of the distortion, possibly do the stent, put another balloon in, and try and do a lot of ballooning to see if we can manage to get the stent roll back. But it wouldn't roll back, obviously, because it's distorted forward, and this is an abraded area where there was supposed to be stent. So we used a large balloon, 4.5 millimeter balloon, to try and do this here, but this doesn't seem to work as it shouldn't work, because there is a eccentric disruption here. So you should not leave ideally an area of stent distortion in this area with this denuded endothelium in the left main. So despite the fact that the rest of the LED looks okay, the LED is looking okay, but this area is not. So I'm gonna put another stent now, and we have to place it very carefully, and we have to do it in multiple views. And so we have to do it in multiple views, and just make sure that this time we don't miss the ostium. So this is and you can see that once the stent starts deploying, you can see how it is gonna go up. If you look at this with the stent going up, you can see that it goes up eccentrically in a dog bone manner, showing that there is some non-resistance here and some resistance. This again is how, the stents usually go up symmetrically, but without much dog boning. So you can now see that we've crushed this material, and now it becomes simple. A lot of ballooning, and so now we are okay. So this looks okay. So this looks okay. Everything is fine. Good lumen. There seems to be maybe yes, maybe no, a miss area here, but good size. LED is fine all the way down. The diagonal seems to be working fine, and there's nothing. And this area is okay. So this is our final picture, and LED is okay all the way down. You can see it's all the way down, stented here, and it seems, and the left main seems perfectly fine now, and so in the end, not a bad result. So we just show you the final, and we just take it out while to make sure that everything is fine. So we take out the guider and finish the patient stable with good hemodynamics, and let's hope this lasts.
So now this is his post PCI immediate echo, and there seems to be, compared, we looked at it quite carefully, and there seems to be already improvement in the LV function from 30-35 to up to 45% EF. You can see that part of the 16 segments, I think 4 to 5 segments were akinetic or severely hypokinetic. Now there's only 2 segments which are severely hypokinetic, and the rest of the segments seem to be moving well. And so in multiple views. We looked at it, and I think the septum has started moving better in the distal part, not the apical maybe, but the distal part, and some of the anterolateral apical areas here, as you can see, is moving better. The apical septum is not that good. That's the only part that's left on. You can see there was diffuse disease and calcified disease and probably a bit of infarcted tissue. But there's still not too much thinning there, and I think the mid part has now started moving. And overall, look at this apex. So this has been some improvement. And in the 4-chamber and 2-chamber views, I think still, if you look at the apical part of the lateral wall, it seemed to be much better. Only the apical septal part is slightly or maybe hypokinetic. The base and the mid part of septum started. So this is immediate improvement, which is quite good. And clearly one would expect that with the critical left main, with a occluded right, which is collateralized by the left system, the LV is at a high risk of sudden event, should improve in these cases. And I think the more complex the case is, the more benefit the patient will get. And these cases usually would go for bypasses in a normal, but this patient had refused bypass totally. Now, initially, for a few months, he thought that he was told that it was going to be medical treatment somehow or another by the heart team, where he had the original angiogram. But I think there must have been some confusion, because clearly no one would leave him on medical treatment, 53-year-old. So I think overall this patient's really going to benefit, hopefully, if his stents do not show stenosis, etc.